Gail Arno is the Director of Care Management for Elder Care Management. Gail began her career in aging services in 1998, serving as a family consultant for a local placement agency. She actively educated and guided a generation of seniors and their families to resources and information available throughout the greater Sacramento region. In 2010, she brought her experience and expertise to the team at Elder Care Management, providing service and oversight in the growing field of geriatric care management. In 2020, Gail assumed the role of Director of Care Management for ECM, leading the exceptional team of established care managers. Gail received a Bachelor of Science in History from UCLA and a Bachelor of Science in Psychology from CSU Northridge. She also completed a graduate certification program in gerontology through CSU Sacramento, where she concurrently completed a 6-class case management course certification. Gail is a California Residential Care Facilities for the Elderly, RCFE, certified administrator and is a state-approved instructor for RCFE administrators certification courses. Additionally, she's a volunteer for the Alzheimer's Association and a board member for Del Oro Caregiver Resource Center. Gail is also a certified care manager through the National Academy of Certified Care Managers and a member of the Aging Life Care Association. Gail offers invaluable wisdom on the subject of aging. And with that, I would like to pass over the presentation to Gail Arno.
Thank you, Maureen. I sure appreciate that. And thank you everybody for joining us. This is kind of a fun one for me because it's definitely in my repertoire. So I hopefully have some answers as to what care management is all about, because it's what I do day in and day out. So I thank you all again for taking a moment out of your time and listening to what we have to say here, and certainly appreciate your feedback or your thoughts back, your questions as it might be. It's not your norm, and it's not your normal job, I should say, in many ways, but it is a wonderful job. And we, I think those of us who are engaged in it just truly believe in this effort, particularly when there isn't a family member or a loved one or a near and dear friend who can step in and take over some of the day-to-day routine maintenance that we all need in our lives, particularly as we age. So I think it's a critical entity. I think too, in many ways, it's good job security, because I think you and I know I am only but aging. And so it's nice to know that I hope someone will be out there able to support me and guide my family members to proper resources, etc., when my time comes, which won't be that long from now. But I'll probably be the most challenging client than anybody in care management or in facilities, for that matter, that they may get. But we'll play those cards when we get them, as it might be. So again, thank you. I know if any of you have any difficulty hearing me, please let Maureen know through the chat. We had a little feedback last time we did this, so I want to make sure that we're not missing anything in that regard. So without further ado, let's dive into care management and what it's all about and how we go about providing this service to clients. So we are managers of the Health and Human Service entity. We are specialists in many different things. We try to guide, we support. I think the biggest thing we do, though, is truly advocate for older adults and those family members who care for them. And I think, a perfect example is even just in the course of my day today, I have met already with 3 families, and we've talked about what their futures look like and what their challenges are. And oftentimes we'll have inquiries, and they'll ask me just to send them a template. Could you just send me a checklist? What am I supposed to do? Just send me a checklist. Well, I would contend to you folks that, we're all unique and special. And so once we get engaged and figure out what the major concerns are, yes, then we can create some sort of checklist pursuant to your uniquenesses and your needs, as it might be. I would tell you that there is hardly one similar case after another, just like there's hardly one similar human after another. We all come to the table with very different needs in that regard. You know, just simply in the course of today, before we started this, I had met with a husband and wife and 2 adult children. Both of neither live in the direct area. The adult children have lives and careers of their own. Their parents are safely, for the most part, and securely, definitely securely, ensconced in their family home of 51 years, and they don't want to leave. And neither parent is aging, you know, in symmetry. The trajectory is divergent. It goes in many different angles. And so, you know, we had a good 2-hour discussion of how lives don't age in unison as we might have spent all that time in unison. So, you know, that was the first 2 hours of the day. The next hour was checking in on a client that has just recently secured our services, who are very intelligent, very educated individuals who never had children, who don't really have any nieces, nephews, or even extended family in this area. And they're so used to managing on their own. It is like, really, we have to wrangle with them to let us do anything on their behalf, because in the past, they've always taken care of their needs. They've been fiercely, fiercely independent. Well, open heart surgery will change your fierce independence and make you a little dependent. So we're working with them on how to try to accept some help. And then thirdly, today, I saw a delightful older couple with a 60-year-old son who they have put a loving safety net under, but it's not a good safety net that's going to last him eternally while they go about living their lives and closing their lives down. And I did leave them with the thought that nobody's getting off this planet alive, and they are going to have to likely make a plan for the time to come when they will not be here, and their 60-year-old will need the guidance of a professional. They don't want to burden the siblings with this responsibility. So better now to plan for what the future looks like, so you have choice and decision making instead of trying to wing it when the curtain comes down, as it might be. So again, specialists in many ways, but we serve a broad spectrum of clients in a broad way. We try to take as much of a holistic and client-centered approach to each of our clients' wishes and wants, trying to problem solve their most challenging situations in periods of uncertainty and periods of certainty as well. As I mentioned, it's pretty certain that we're all going to need some assistance and as we go through this aging process in some way, shape, or form. So many of our clients, my clients, say to me, I just want to go to sleep and not wake up. Well, that's ideal, and everybody wants that. But, you know, what's the road to getting to that? And there's no guarantee we get there. So let's put solutions and services in place that support you. One of the things that we have felt really strongly about is that you're better to plan ahead and educate ahead, particularly in time when a crisis comes. This is not the time to be doing your education and your information gathering. You should be doing that before the crisis hits. And I'm going to contend that every one of us is really in the midst of a crisis at this point, with the unfortunate presence of the COVID pandemic. And so the crisis has hit. And now when we have challenges, we are just taking one crisis and putting it on top of the next crisis on top of the next crisis. So all the more reason to have those situations, solutions, resources in your back pocket. And that's something we're really fond of. We often talk to families, particularly new families, about plan A, plan B, and plan C. It isn't just enough anymore to have plan A. It really just doesn't work quite well. We are, as an organization, we're members of the Aging Life Care Association. We're very proud of that affiliation. When we started the company almost 12 years ago, we're heading into the 12-year anniversary. This was a great organization that's been in existence for 30 years. And we just found that their ethics and guidelines and boundaries really gave us a platform with which to jump from their ethics, their values, their experiences to create our own value system and ethical boundaries. Everyone on our team has a bachelor's or a master's degree in a field related in whatever way, shape, or form to aging. And we follow, again, the standards of practice and the code of ethics that ALCA, or the Aging Life Care Association, encourages us to follow. And we believe in it. We really do. I think it's an excellent guideline for us in that regard. So where do we work and what do we do? You name it, we do it. We are often in the client's actual home, wherever that may be. It could be their own private home. It could be a residential care setting for the elderly, both large and small. We're happy to be in any environment. And I did placement for many, many years, and I believe there's a pot for every lid out there. And so places to find, we don't do that, but we believe in that effort, and we believe wholeheartedly in the rules and the guidelines and the support that one receives in an RCFE or a residential care setting. We have a number of clients in skilled nursing facilities, either in a custodial or permanent capacity or in a rehabilitative capacity as well. And we also see clients in the memory care world of the residential care setting. So our clients are here, there, and everywhere. We serve we don't like to be any more than about 45 to 50 minutes from any of our clients. We try to pride ourselves on being a 24/7 crisis response. If we're 2 hours from our client by physicality, we're of no value to those clients when they're in an emergent situation. We manage and attend doctor's appointments. We go to emergency room visits. We stand in on hospitalizations. We've gone to court as a good reference to viability, feasibility, and a neutral party that speaks to the success or the failure. And I had one this week that I was completing for a gal. The court had called and asked for an assessment as to her current setting, which was an RCFE, but also was it appropriate and would it be feasible and viable for her to return to the family home? And I was more than happy to take a peek at meet the client, talk to the staff at the facility that she was at, meet the current conservator, go to the home, visualize the home, and see how it would be, what would be needed to be done, and how one would tool the home to readdress her current needs, etc. So that's not an unusual call for us as well. And again, we're a nice, independent, neutral set of eyes to try to clarify what we feel. We have no dog in that fight whatsoever. And often there are fights in that regard. Again, we're a 24/7 crisis response and support mechanism for our clients. We're not going to come in and be diagnosticians. We do have a nurse practitioner and an RN on our staff. I don't let them do any nursing per se, but it's lovely to have their science and their brain and their insight. They manage clients as well. We will do med trays, and we'll make a call to the doc and try to talk about medications and where we might be able to streamline, or are they aware that the client isn't responding to this medication, etc. And we will be happy to step in and try to be that liaison and that spokesperson based on the wishes of the client or their responsible party. We pass everything by the responsible party to make sure we're not overstepping bounds in that regard. And as it says there in the last bullet point, and I think this one is a really important one, we're exclusively care management. We work with and we refer on to those proven senior providers that we know can address our clients' needs, that are more cost effective for our clients, because at our price point, we should not be doing grocery shopping and dishwashing and showers, etc. There are individuals who can do this for clients at a much better price point than we can, but we can get that individual lined up. We can oversee and make sure that individual is doing and providing to the client what they need, but we try not to step outside our scope of care management. We do not do placement. that is really ethically something that ALCA or the Aging Life Care Association is very opposed to, because there are specialists who provide that service in our area and they provide it for free. So we should not be charging someone so that we would learn more, a little bit more about facilities that are out there in the industry. I will say we aren't in facilities and we see a lot of them. I know that there are some pretty doggone special facilities out there, really wonderful. And we're always happy to directly refer a family to that particular setting and then also get them a resource or two in regards to placement, oversight, and execution. So again, we really try to stay in our lane. Our lane's pretty wide at times, and we have a lot of broken yellow lines, and so we cross, but we only cross in that crisis situation where we're supporting our clients. I think a really good example of this is I had a client at one point who was a delightful, just a character of a gentleman, never married, single all his life, lived at home, was a probation officer, and owned a hunting club. So for this gentleman, guns were just a really normal part of his everyday life. And he had quite a cachet and they were displayed in his home. And we had to bring in, he wanted to stay at home desperately. He had the funds to stay at home. So we brought in some caregivers and the guns made them very uncomfortable and rightly so. But to take this gentleman's guns away from him, I might as well have cut off his right arm because it was such a familiarity and such a comfort to him. So in lieu of taking away his guns, we had the caregiver take him out for an extended afternoon. And I brought in a gunsmith who actually jammed the firing pins on the guns. We took all the ammunition out. We filled the ammunition boxes with sand, so they felt heavy. If you picked them up, he wouldn't, unless he opened it up, then he was going to be really mad when he found out there was sand in them. But we now had, the guns remained in the home. They were unusable, unknown to him, and the caregivers were at ease. And that to me is a win-win situation. So those are the kinds of things we just have to brainstorm a little bit. And with a staff of 7 total, we get some good collaborative brainstorming. What I don't think of, my partner in crime, my colleagues will think of as well. So who do we support? Oh, we support some of the challenging ones, no doubt about it. You know, it would be really nice to see if there was, you know, someone who was not challenging. We'd love that too, but we don't always get that. So we do take the complex medical issues, not again that we're medical, but we certainly try to better understand, you know, exactly, you know, what's going on, and our nurses can take looks and help decide that that needs to go to the doc. We need to get a specialist. We need to pursue Kaiser outside the PCP, etc. So we really try to make a difference in that regard and help with those, I don't know, break down those complex medical issues if possible. So a really important task for us, definitely. Another thing we do, those who are resistant to care, you know, we want to just maybe be the neutral person that's just going to come in and say, you know, I hear you. I know you're resistant. And I did this morning, a perfect example again, sitting with this couple that mom says she doesn't need anything. She's fine. Mom needs a lot of help. I leaned over and I said, I know you don't need it, but these wonderful adult children that you raise, they need you to accept a little help. They'll sleep better at night. They'll do their job better during the day, not having to worry that they would have to come your way and try to you know, solve a problem in the middle of the day when they really needed to attend to their own lives. I think that's why we raised them. And that's why we brought them into this world, was to raise them up so they would have that ability to you know, meet their own needs and not be in the middle of things for them and for us, as it might be. We do tend to, you know, draw on combative and aggressive behaviors. And we want to help with management of those behaviors, offsets of those behaviors, contouring to those behaviors, particularly in the RCFE, to support what they're attempting to do, but also to mitigate, if possible, some of these behaviors that don't that we just don't know much about, or we just haven't been able to quell, etc. So we work with families, we work with docs, we try to work with the facility. If as a good example of this might be, we had a son and a daughter, two daughters. Just recently, their father had to move into a facility, and they have had a hard time grasping what his dementia, and how their phone calls 2 and 3 times a day are actually agitating him, as they call and check on him and want to talk to him. We were happy to intervene there and remind them and educate them a little bit on this disease process, and suggest to them, that these phone calls are not helpful. What else would make you feel comfortable? Would you maybe just at least talk to the staff? Would you like us to go over and put our eyes on them so that we can confirm that they're healthy and they're fine? What do you want to try to mitigate some of these behaviors? We're going to think outside the box a little bit and try to help them just a little bit. We get a lot of poor decision makers, folks. They think they're doing just a bang up job and making, sometimes doing nothing is a decision. That's not a great decision. So we work with individuals who have poor decision making skills. It is important to, again, as we've said, have plan A, B, or C, and you're working any element in those plans A, B, and C at all times, just trying to figure out how can we help this individual make better decisions so they're safe and sound. As I was talking with this family earlier this afternoon with their 60-year-old son, again, one of the big issues I was suggesting is that they put formal mechanisms into place to support him, such as a fiduciary or a conservatorship, and do this now when you have choice, and that you can drive a good amount of it and you can discern it, you can direct it, work in conjunction with these systems. You do it when you're gone, or it has to automatically be put into place when you are gone. You're going to find organizations and entities that aren't going to be as compassionate as you might be. They'll do their job, but they're not going to worry about the history of. They're going to worry more about the concern today and get things in place. So again, always best to do the education first and then make some decisions. We see many that are non-compliant with medical or with health orders. We do a lot of consoling, cajoling, encouraging, but bottom line, individuals who have who are not deemed incompetent and not diagnosed with a dementia diagnosis, and in those moderate to latter stages, they have the right to be non-compliant, make poor decisions. They're adults, but we perhaps can come in and verify what the outcome of those poor decisions and those non-compliance issues might present down the road, and see if we can get a buy-in for that individual. We do a lot of hand-holding in that regard. We do have families who are not always in agreement, and that's understandable. Everybody plays a different role in the family, and you get 2 or 3 siblings or more in a room, and it is hard to get consensus. And so we're happy to come in the middle. I know at one point I had a family with 9 children, and we had 2 docs and 1 lawyer and 2 professionals, and they couldn't, and they were a great family, and even they couldn't agree on what they all thought would be the best next step for dad. So again, a little mediation, a little neutralizing of the situation, and a neutral stance on all of this. And we'll tell it like it is. We will be very direct, gentle, but firm. We are not going to sugarcoat anything for anybody. Nobody makes progress in that regard. So we will speak up and agree to disagree on things from time to time. We do see some financial or fiscal abuse that concerns us. We see that we are mandated reporters, so we will step in and contact APS. We will contact family members. We will even contact APS on family members, which is unfortunately more frequent than I'd like to acknowledge. But certainly making sure that the rainy day that these seniors saved for is not negated because they are not able to discern that the financial situation that they're in the midst of is not a healthy situation. And we've seen, sadly, more than I think our share of that. We're just saddened by that, but happy to jump in and get the right people in place to support it. I think more and more we're seeing undiagnosed or long-term mental health issues unaddressed, now coupled even with some dementia or recent dementia diagnoses. This is that dual diagnosis that is often so very difficult to rein in and address. So we're happy to work with dementia specialists on top of psychiatry. The resources are limited. I'm not going to say this is an easy transaction, but we're happy to work with those individuals and try to get in place the safety net that would be very helpful for this individual. So again, we support those clients from wherever they come to wherever they want to be. And they are always, as we're very fond of saying that they're kind of like an onion, and we're just slowly peeling back the layers to get to the core to better understand them. And we also recognize that we didn't likely create, we certainly didn't create the dysfunctionality or the choices or the history or the life study of this individual. So we're not going to solve it, but how can we support it so it's safe, it's neutralized, and it's mitigated if possible? So again, some ideal client candidates for our support and our service might be an involved family, but yet they live out of the area. And that was exactly what I experienced this morning. Delightfully intelligent, caring, 2 adult children who are both in the Bay Area with thriving careers. Mom and dad are safely ensconced here in the Sacramento and surrounding area. And you could see the physical, palpable relaxation of the shoulders of the children as we were chatting this morning, the adult children. Whereas you could watch the parents' shoulders kind of rise, like, oh, people will know about us. There will be strangers in our house. So it's quite interesting that you get to kind of see that visually. But that's a great client for us, and we communicate well with that, with those interested or responsible parties, keeping them abreast of what might be going on. Oftentimes, we have no family or no family involved. And we've had our handful of either no children, no arm's length relatives. And we've had families, or we've had clients who they have alienated all of the family, and the family is burned out and tired and overwhelmed. And again, we didn't create these problems. We didn't create the buttons. We're not, the loved one isn't going to be able to push our buttons. So it's nice to be able to come in and be neutral about all of this and not take these things personally. Some days we do, I'm not going to lie to you. We tend to really adore our clients in no short time. But again, it's not about what we are seeing. It's really what we're doing to support that client. Sometimes we get families, again, that are unable to agree on any sort of plan for aging. So we are often really in the middle of supporting all ideas and then vetting the ideas that are really going to hold water and work for their loved ones, and expressing to them why that may not work and what really does exist, and how you go about getting them. I think we all have complicated family dynamics. I distinctly remember, and I share this often, excuse me, that there are 5 of us in my family, and my parents are both gone, unfortunately. But after my father passed, it's so very different when you're advocating for just one parent. And so we got down to the, kind of the end of things with Mom, and we sat around the table and we were talking about things. And my youngest brother kept, he'd pipe up every once in a while, say, but we could try this. And, invariably we looked at him and said, what would you know? You're the baby of the family. Well, he was 45 years old. He wasn't a baby any longer, but that was our perception of him. And, I'll be honest, he had a few good ideas that we sort of gently finally came to. So family dynamics can always play a role in our clients' world, and it typically does. Some of the emergency events tend to overwhelm family and decision makers. And furthermore, if you are the decision maker and you are 2,000 miles away from your loved one, it takes time to get in on a plane and get across the country. And in the last year and a half, you couldn't get on a plane and get across the country. Now you may more readily. We are the feet on the ground. We get up at 2 a.m. We get out there, we find out what's going on. We immediately get in touch with the family or the decision maker, and we let them know, you know what, it's okay. It was just an unobserved fall. We got a little steri strip right to the forehead. The scan is clean. Go back to bed. Don't get on a plane. Or we get on the phone and we say, this looks quite serious. I'm going to stay with your loved one. When do you think you can get out here? So we will definitely be that intermediary again to discern, is there a need to get up and get moving? Or is this just yet another mild event, mild little blip on the scope of their overall care, etc. We work a lot with those who are conserved or the POA is unable to provide oversight. We will not become POA. We will not become conservator, but we will work in conjunction with the conservators of the POA. Oftentimes conservators who are wonderful folks, but really their expertise and their knowledge really falls in the world of finances and court responsibilities, safety measures, financially, etc. They often call on us to come in and essentially just work with them on the psychosocial side of things. Certainly med management if they're not in a facility, but the psychosocial side of things where we can be available to quell issues, to address concerns, and then report back to the conservator, letting them know that, yes, we got groceries in the house, we've set up a caregiver, the caregiver is going to be coming on a regular basis. This is what it's going to cost. We'll oversee the caregiver as far as schedule, etc. We recommend the following agency, blah, blah, blah. So again, the conservators don't really care to do those finite details, and we are delighted to do those finite details. And we are happy, to work with a challenged family or support system that just can't do this any longer. As I mentioned, it's very difficult and very draining. And I would say too, often we see again this long-term relationship, 40, 50, 60 years partnered and married, and now all of a sudden mom can't cook the meals that she's always cooked and dad can't cut the grass. And so again, coming in the middle to establish a better support system, define roles a little bit, and excuse the individual who's always been the lead in the family to sit back and receive the care that they are in need of too. It's a very difficult balancing act that people are up against. The good of one doesn't outweigh the good of many. So we're trying to spread the wealth and make sure that our individuals are not acting in the previous roles that they had acted in all their lives. And if there's a family that cannot manage to support this, then we're happy to be that support system in that regard. Very, very helpful in many, many ways to our clients. We love partnering with senior communities. We like assisting families as an example, in confirming their decision to move into a specific, an RCFE that they've already established. We're pretty creative in regards to getting the scenario created that gets them to move. Sometimes we work a little sideways. We aren't always direct with individuals, that it's a little easier to accept that, oh, I must go into a facility because the roof on my house is leaking. Oh, okay, I understand that. So we work definitely to help families sculpt this scenario. We are firm believers that, if there's any cognitive challenges, you don't give your loved ones, weeks and weeks of pre-information about a move. It does nothing but unsettle and unnerve and create anxiety. we're happy to confirm with families and why they've made this decision, or what, where their decision, where's their limbo in this decision. Always happy to tell them that, you've made this decision, you came to it, let's talk about it, and then let's talk about how you actually make this happen. And giving them some guidelines on giving the facility some time to adjust and gain trust in the facility. Sometimes leaving individuals alone for a couple of days, if not a week or so, to get settled into their facility can be beneficial. We try to give them all these little tools, which likely the facility has done as well, but it may not have been heard. So we want to support their decision. And if they decide that they want to stay at home, we're happy to assess and really lay out what what the challenges might be of staying at home. If they've already gone this far and presented this information and chewed on this information, there was a reason that they came to this conclusion. We always want to help mediate with residents and families who might be struggling in an RCFE setting. I happen to be an RCFE administrator, as do a number of the care managers on our staff. I actually teach for the state of California the RCFE initial certification for administrators, and also the continuing education units for those administrators. I know the rules and regulations quite well. And it's always nice to be able to say to the families, what you're expecting is really outside their scope of service. And this is why, and how can we best support you remaining in place and put a little bit of an additional safety net that the facility cannot provide for you. You're asking them to go outside their scope. Or we're always happy to come to the facility and say, here's the feedback we're getting. How do you think we can mitigate this? How can we support so this resident can stay with you and make this work for everybody? And I think furthermore, I've had a time or two where I've had an executive director call and say, can you help get this person out of here? Because we just can't meet their needs. And we've tried, we've bent over backwards, and we don't feel it's a good fit at this point. So we will support whatever way is best for the client, but also be very realistic and information sharing with the family or decision makers. Again, as I've said before, we're a neutral third party for families or decision makers. So I can't tell you the number of times I've met with a family and I've spoken to the adult children or the responsible party, and I've basically gotten a background and understanding. I feel I go in, I do my assessment, and I sit down with everybody, and I tell the parents something, or the parent or parents, and the parent says, well, that's a good idea. And the kids' jaws are dropping because they're like, goodness gracious, we told Dad that 2 months ago and he didn't hear it. Something about a badge, a name, coming in and just saying, oh, I think this is what you should do, tends to neutralize it. And I'll often say to the adult children, I know you got there first. I just came in to finish the job that you started. We often act as a go-between to the facility and the process, and making sure that, that the process occurs, that either moving, we're happy to try to get some of the paperwork done, a sense of the packing, a sense of the acceptance, the time frame. I had a client call not so long ago, middle June, and seriously considering pulling her dad out of the facility. He'd moved June 1st, and he keeps asking to go home. And, it was very simple for me to say, that's not much time at all. Breathe. Of course he wants to go home. It's all new. It's all different. It's a big change. Sit still and nod and understand and be empathetic and hear it, but realize that this takes some time. So we're kind of that go-between. Talk, and we'll say to them, talk to the executive director, allow us to talk to the director who will talk to the staff, etc. I think that we are happy to be that intermediary, to really make this work for people and make the best outcome that we can possibly make. And I think we additionally bring some unique and complementary resources to the RCFE setting. Something that we might find that maybe the facility just doesn't have as part of their resource. we make sure that they get that extra hand. If the dog needs to be groomed, we'll get that dog out and get it groomed. We'll get the shots updated. Last weekend, I spent the weekend, like this one, with a cat. I don't have any cats. I have 2 dogs at home, but we had a client who had to be out of the facility for a couple of weeks because of a fall and a further, medical concern. The facility really didn't want to take care of a cat. And so there's a unique and complementary resource. We took the cat home for a couple of weekends to make sure that the cat was safe and sound, and hoping to encourage the client and the resident to get better quickly so she could get back to her cat. We try to be as creative as possible in those scenarios to make everybody feel a little bit more quelled and a little bit more supported, as it might be. We are just a little bit about what care management looks like. I wish I could tell you that it is for everybody. It's not. It is mostly for those of the healthy pocketbook. I wish that we could serve all of them, but it is a private pay fee for service at this time. One of the particular things that we really enjoy about the ALCA, or the Aging Life Care Association, is this affiliation with a national organization that is continually lobbying to make our job more visible, more viable, and financially wise to our entire system. And as a specific example to that, wouldn't it be lovely if every employer offered an EAP where you got 10 hours perhaps of this kind of service for guidance and cueing into and education into what is available to you? Wouldn't it be just wonderful if Medicare provided 10 hours of care management for everyone, so they could make sure their ducks were in a row and their needs were being met? We're not there yet, but that's a proactive step that might save, in the long run, a tremendous amount of money. This is a hard sell to Medicare and to the federal government because they like really tangible numbers. And we're a little bit more touchy-feely, psychosocial, but I would tell you that without exception, I feel very comfortable saying 99.5% of our clients walk away from their experience with care management knowing that they navigated with better ease, they made better choices, and they preempted crisis to a certain extent, and they were able to manage better. So rates do run anywhere from $120 to $200 an hour. It depends on location. We don't apologize for this. We are all skilled professionals, and I think this investment is very worthwhile. Certainly $120 to $200 an hour saves on an airplane flight across country, which could at last minute notice be $1,000. So again, we really don't apologize one iota. We only charge for that with which we work for. So if we are not working for you, we are not charging. And we in our practice, we bill to the 6 minutes. So if I'm writing an email, if I'm making a phone call, if I'm doing research, I will bill for that time. If I'm visiting, if I'm traveling to visit, I will charge for that time, and we'll charge for that 2 a.m. call that gets us up out of bed and gets us onto whatever location it might be to serve the support the client. There are a few scenarios where long-term care insurance policies will perhaps pay for our assessment or a little bit of our interaction with individuals. But for the most part, again, this comes back to being private pay, a fee for service. We as an organization don't have a minimum contract or any deposit required, but we do ask, if we are going to do services for someone, we do ask that we have at a minimum a once a month client visit. This gives us a chance to assess change, to make note of change, to get updates. Particularly in a facility setting, we can find out, oh, you sent them out twice. What happened? Oh, 2 falls. oh, medications were changed. We're a better historian and advocate for that individual at the off hour, during the on hour, but particularly at the off hour in an emergency, as long as we have the most current update information. So it's really important that we see our clients minimally once a month. I will tell you that some of our clients we see 3 times a week. Some other clients we see once a month. It really, again, as we talked about at the onset of this is really about a very unique care map for each and every individual. So if it is just simply that minimum monthly check-in reassurance, then that's wonderful. If it's more than that, we're up for that as well. So it really, again, it's a very unique circumstance catered to each and every individual that we take on as it might be. So what's the impact? I think it's a billion-fold, but I know I'm biased. Again, as an example, we save that family money because they don't have to jump on a plane or address an emergency. We'll take that 4 a.m. call from the RCFE or from the home. Doesn't matter, when the client has been sent to the ER and we get there right quickly. And we get there as an advocate, so we're able to really walk in. I have very rarely, with the exception of COVID, very rarely had an ER that said, yeah, we don't need you. More often than not, they're opening the door saying, oh, you know something about them? What's the deal? Tell us all about it. What's their history? What's their meds? We're able to really help and act as that historian. And give the ER a bump up on their effort with this client. You might wonder very quickly, and I'll give you our structure, how do they do this 24/7? Well, again, there's 7 of us in total, and we all do our Monday through Friday efforts. 4 of the primary care managers take 1 night a week, and then bless her heart, our most adored and loved employee, and not because she's the nicest person, but she is. She is our weekend person. So Friday night at 5 o'clock, we all check in with our dear sweet Judy. We give her an update on anything brewing, any concerns we have, and Judy takes the phones from Friday night till Monday morning. And she addresses issues. She sees clients. She follows up on details maybe that we weren't able to get in place during the week or that have cropped up late in the week and might need addressing over the weekends. And she will talk with the family. She knows the history of everybody. She has access to their backgrounds. We really adore and appreciate this because it gives the rest of the team that chance to really rejuvenate, refresh, and be ready to be back at the ready with our primary clients. We are beyond delighted to have that structure in place. One of the things I think we're quite good at is getting clear documentation, clear diagnoses, making sure that orders are signed correctly, particularly when someone's going back into a community. Can't tell you the number of times, and it's mostly, I'm sorry to pick on this, but it's mostly Kaiser, where I hear the doc say, okay, we're going to add some ibuprofen, and for pain relief, she can have it, twice a day. Yeah, doc, can you put that in writing? Oh, no, it's in the discharge paperwork. No. I need it in writing, signed. I need exact dosages, exact timing, etc. No, it's in the discharge paperwork. You just go and pick up the Tylenol at the pharmacy. They live in a facility. We need some boundaries, please. And eventually they get it. This is something you might walk away from as a family member not getting it done correctly. We also share every diagnosis and every detail of any doctor visit or emergency room visit with family, so they're as up to speed as possible. We love going to doctor's appointments, arranging those appointments. We are scribes. We are taking down notes minute to minute, making sure we pick up every nuance that's shared. We then subsequently share it with the facility and or the family. We'll pick up those prescriptions. We'll provide medication management and oversight. We'll order meds. We'll pick up meds. We'll fill med trays for those at home. You name it, we're happy to do that. We're always happy to be present for that doctor appointment. There is anybody on this planet that wouldn't do just a little better with a second set of ears as they go and visit and see a doctor, so that everything is heard on all parties' behalf. And again, we try to help those RCFEs keep those residents who might be challenging and facilitate a move if the current setting is no longer appropriate. Happy to jump in one way or another. If we can quell the issues and support the issues in the facility, great. If the facility has said this is more than we can do, then we're going to start the process of finding the resources to get them properly attended to where they need to be. I think we can be a great partner with many of our facilities and many of our families that we work with. Resources we refer to, we work very closely with fiduciaries, conservators, financial advisors, docs, the POAs, the home care agencies. I think we've created a wonderful resource list, and we've got history, years behind us. These are resources that have been vetted and utilized quite well. And so we're very honored to refer to these individuals. We're always growing our resource list, and we always love feedback on resources from families if they don't work or if they do work. We try to identify those needs, and then we refer the support to those needs to a qualified vetted resource specialist to address it. We can't do all things, but we can orchestrate many, many things to individuals, and we shouldn't be doing all things. We need to find the appropriately skilled professional to provide the services that are outside our scope of service. Why choose elder care management? We have 6 care managers and our lovely Maureen who supports us. We have a boatload of experience in the field of aging. We're a very collaborative, supportive, thoughtful group. We have to work together to solve all of our clients' concerns. We have RN care managers. We have a nurse practitioner care manager. Again, we advise and advocate. We don't do nursing, but we sure can do an awful lot to support that effort. Again, as you heard me say a number of times, we're 24/7. At any given time. It doesn't even have to be an emergency. A human answers that phone. We are coming up upon our 12th year of business. We're so proud and pleased. I was the first care manager that we had, and I'm honored to know that we've grown to the size that we have and that we serve the population that we serve. And we are so committed to community education and partnering with local care providers to offer some free educational presentations, much like this one today. Always happy to talk about what we do, we feel we know best, and to support the community at large of aging, and so that everybody has the most knowledge that they can have. This is a perfect format for us, and we're delighted to be able to share this with everybody and anybody at no cost. That's a critical part of our to-do. Just in closing here, we have a slide or two more, so bear with us. I'm the one who does the initial phone consultation. Always want to talk to somebody on, initially to just see if we're the right source, and if we're not, I want to move it along to the right source right quickly. I don't need to waste anybody's time in that regard. If we come out to the home to do an assessment or a discussion, an information session, we will charge for our time. But again, we're doing a care assessment at that time catered to that client's individual and unique needs. We'll do a written care plan. If someone wants a very detailed outline of short, long-term goals, recommended services, observations, etc., we will put that plan in writing. Absolutely happy to do this. All of this outside of the initial phone call are involved in our fee for service. And then again, we'll do the ongoing care management, able to adjust the plans along the way, add additional resources, as physical, social, and cognitive issues adapt and change for the individuals, we want to adapt and change. So we love nothing more than starting with them and walking them all the way through to the close of life and making sure that experience is comforting and easy and peaceful, if nothing else. So we start initially with, again, vetting, trying to see where we might lie, and then we take it from there in establishing a relationship, trust, and some commitment with the family members and the loved one that they're concerned about and that we ultimately are advocating for. So So this is us. I'll shut up now and let Maureen kind of take it from here, but I'll stay on board and answer any questions that might arise. I want to thank you all for taking a minute to listen to our little dissertation on care management. I think this is an industry, as I mentioned, that is going to do nothing but grow. It's an industry that I think you go to bed at night for the most part, feeling like you have made a difference in someone's life. But we also go to bed at night worried and concerned and wondering, did we do all we could do for that loved one? I think some of us, I think all of us wake up sometimes with a start and realize, oh, I could do this. I could help them with that. So I think this industry is going to do nothing but grow, and we're delighted to be a part of that growth and hope to be present and available at every turn for all of the inquiries and all of the clients that we serve. So much thanks again. And Maureen, I'll truly hand it to you at this time. So thank you.
Thank you so much, Gail. I think everyone has a better understanding now of care management services and when it can benefit. We did have a few questions come through. I'm going to go ahead and stop the recording at this time and start the question and answer session. You can still chime in on the chat if you have any other questions that come to mind.